So imagine you run a multi-billion-dollar health insurance company,
Nice work if you can get it.
and your whole model depends on telling other companies what treatments and drugs they should cover for employees.
Good seat at the table.
Usually. But now imagine you drop coverage for a hugely popular class of weight loss drugs for your own roughly 67,000 employees because the math is too ugly for your own bottom line.
And that's not hypothetical. That's happening.
It is. We're watching the people who built the financing architecture admit it can't carry modern medical innovation.
So today, the battle for cost control, why coverage feels increasingly hostile, and what is shifting underneath it.
We'll connect a $13,000 an hour billing anomaly, the economics of employers cutting GLP-1 coverage, and why Walmart wants to be the new front door to care.
And the big idea is pretty simple. Traditional insurance control points are breaking down.
For years, the game was lowering the unit price of care, push down the cost of a bed, a pill, a procedure.
Now the fight is over the infrastructure itself. Who controls the pathway of care?
And insurers are losing control of those pathways.
Which starts with the risk pool. Before high-cost drugs, ask whether the baseline coverage structure is even stable.
Start with Medicaid. CMS issued interim guidance effective January 1st, 2027, creating a national framework for Medicaid work requirements.
Meaning certain adults aged 19 to 64 have to meet an 80-hour per month work or community engagement standard to keep coverage.
And the administration's stated goal is transition. Move able-bodied enrollees off Medicaid and into the employer-sponsored commercial market.
Sounds neat on paper. In practice, the problem is operations.
Reuters says $200 million in federal grants is going out to help states build the tracking systems, and governors are already warning the rollout is mathematically unworkable.
Not just because of volume, because the IT isn't built for this.
Right. Tracking 80 hours a month for millions of people often means legacy mainframes and manual document checks, not elegant modern systems.
So a blurry pay stub, a misread community service log, a form that doesn't parse properly, and somebody gets disenrolled.
Which means a technical failure can present as a policy outcome.
And then the cost moves. If someone loses Medicaid because of an IT glitch, their underlying illness doesn't vanish.
They show up uninsured, often in the emergency department. The hospital absorbs uncompensated care, then pushes for higher reimbursement in commercial contracts.
So Medicaid administrative churn can show up later as higher premiums on employer plans.
And that commercial market is already strained. KFF data shows ACA enrollment is down 5% nationally,
with projections showing a decline of 17 to 26%.
At the same time, average deductibles on ACA plans jumped 37%, from $2,759 to $3,786.
So the lifeboat now costs almost $4,000 to climb into.
And once deductibles reach that level, healthier people start opting out.
Which leaves a smaller, sicker, more expensive pool. Classic adverse selection.
Healthy people leave, the average cost rises, premiums go up again, then the next layer of relatively healthy people drops out.
A financial spiral, and people feel it. J.D. Power has commercial health plan satisfaction at 562 out of 1,000.
53% report recent premium increases, and only 30% see their health plan as a trusted partner.
That's the trust problem in one number.
Now drop a high-demand, high-cost drug class into that shaky market, and the budget cracks widen.
That's the GLP-1 paradox. The Wall Street Journal says roughly 1 in 8 U.S. adults has used a GLP-1 medication like Wegovy or Zepbound.
Huge uptake for a relatively new class.
But commercial coverage for weight loss is stalling around 50%. Then Reuters reports that Cigna is dropping GLP-1 coverage for weight loss for its own roughly 67,700 employees effective July 1st, 2026.
They still cover diabetes, but not the obesity indication. That's a very clear market signal.
A major pharmacy benefit manager is effectively saying broad access to chronic weight management therapy doesn't fit inside annual employer health budgets.
Meanwhile, the public side is trying a different route. The Medicare GLP-1 Bridge program starts in July 2026.
A live test of whether the government can build controls, step therapy, and utilization management without capsizing Medicare Part D.
So public coverage is trying to create a managed lane, while commercial coverage is putting up barricades.
Although the corporate logic deserves some pushback, the time horizon may be wrong.
Because the material here points to downstream effects. We have research showing that 3 years of these drugs lowers the risk of needing a knee replacement by nearly 5% over an 8-year window.
Which is not trivial. That's surgery, rehab, physical therapy, time away from work.
So the obvious question is whether employers are stepping over dollars to pick up pennies by cutting access now.
Clinically, fair question. Structurally, the issue is turnover. Employers manage 12-month budgets, not lifetime health trajectories.
The pharmacy spend lands immediately, roughly $1,000 a month. The surgical savings may show up 5 to 8 years later.
And average job tenure is about 4 years. So Company A pays, and Company B gets the healthier worker.
Company A might spend $40,000 over 4 years, improve metabolic health, then watch the employee leave. The lower cardiovascular and surgical risk goes with them.
Which means the first employer absorbs the cost and somebody else captures the benefit.
There's no clean mechanism to recover that return. So benefit managers behave defensively. They protect the near-term pharmacy budget.
Rational on a spreadsheet, miserable for the patient.
Still, if the Medicare Bridge program shows sustainable use at scale, commercial plans may face stronger pressure from employees to match it.
So while employers stare at rising pharmacy spend, they go looking for savings elsewhere.
Which takes you to aggressive audits and some ugly findings in high-growth specialties. The Wall Street Journal's reporting on autism therapy, ABA, is a good example.
From 2021 to 2025, spending by large employers on ABA doubled to $108 million, while the workforce grew 457%.
That kind of growth tends to outrun oversight.
And the journal found instances of questionable billing reaching $13,000 an hour.
Which sounds insane, but the mechanics matter. This can happen through NPI piggybacking, using the national provider identifier of a higher level supervisor.
A private equity-backed clinic hires a lot of uncredentialed or entry-level technicians, then bills their concurrent therapy hours under one board-certified supervisor's NPI.
Using generic modifier codes so the payer's system sees the top-tier identifier and processes the batch.
On paper, one supervisor gets billed as if they worked 50 hours in a single 60-minute window. That's how you get to $13,000 an hour.
The point is that payment integrity systems are usually built to catch coding mistakes, not temporal impossibilities across batched claims.
They can spot the wrong box. They're less good at noticing one person apparently working 50 simultaneous hours.
And when payers try to tighten up, they hit another structural problem, the No Surprises Act and the independent dispute resolution process.
CMS finalized rules to streamline arbitration between payers and out-of-network providers. Better communication, batched claim standards, more efficiency.
Which sounds sensible until payers argue that the efficiency itself can be weaponized.
Because if arbitration gets easier and batching gets easier, private equity-backed provider groups can automate the submission of large numbers of slightly upcharged out-of-network claims.
Flood the zone.
Exactly. The payer's analysts, human or algorithmic, can't sort the nuances of thousands of disputes in the available window, so the burden shifts to the payer.
And often it's cheaper to settle than to fight every claim one by one.
So the architecture of arbitration becomes part of the margin strategy.
And if you're the patient, what you experience is the downstream effect. Premiums rise from cost shifting. Employers carve out expensive but potentially transformative medications because they can't capture the long-term return. And money leaks through billing and arbitration games.
Which helps explain why patients are looking for workarounds outside traditional insurance channels.
That's where the retail story comes in. Teladoc partnering with Walmart for virtual urgent care, dermatology, and nutrition isn't just a side note.
It's a response to broken gatekeeping.
Insurers long justified premiums by saying they were the grown-ups in the room. They negotiated networks, controlled quality, audited claims, managed cost.
But across these examples, the gates look pretty shaky. Medicaid churn shows brittle enrollment systems. The GLP-1 wave shows a budget model that can't absorb chronic, high-cost therapeutics. The $13,000 an hour ABA cases show porous claims oversight.
Too rigid for complexity, too porous for arbitrage.
And when the old rails stop working, retail companies with simpler pricing move in.
Walmart isn't just leasing clinic space, it's positioning itself as a transparent cash pay alternative in a market where 75% of healthcare executives say the system is in high distress.
And the appeal is obvious. The virtual visit price is posted. No hidden arbitration subplot attached to a rash.
They're selling clarity,
Which healthcare is made unusually scarce.
So step back, and the pattern is consistent. First, failure in the safety net. Database and work requirement administration create churn, and the cost rolls into commercial coverage.
Second, the GLP-1 conflict. Annual employer budgets collide with longer-term health gains, so access gets restricted.
Third, billing and arbitration structures that can be used for margin expansion.
And together, those pressures push patients toward retail and direct pay options for routine care.
Which leaves the larger question. If the traditional risk pool keeps getting sicker and more expensive, employers keep excluding costly but meaningful therapies, and retail medicine becomes the practical front door for everyday care, what happens to comprehensive insurance?
You start to see a fragmented future. One product for catastrophe, another for routine care, maybe another for drugs, maybe another subscription for convenience.
An a la carte system.
And then the uncomfortable question is who gets left behind when the standard care experience depends on what monthly subscriptions you can afford.
That's the part to watch. Until incentives are realigned, the real cost of care doesn't disappear, it just hides in the cracks.
And right now, there are plenty of cracks.
There are. That's it for today.
Thanks for listening.